Chapter 6 of the text deals with white blood cell disorders, and the very first discussion that we're going to have concerns leukopenia and leukocytosis. Let's begin by reminding ourselves that the hematopoietic stem cell is the progenitor cell in the bone marrow, and that it is CD34 positive. Now, the hematopoietic stem cell has the ability to produce a myeloid stem cell, or it can produce a lymphoid stem cell. The lymphoid stem cell has the ability to produce a B lymphoblast or a T lymphoblast, and the B lymphoblast can produce a naive B cell, and the T lymphoblast can produce the naive T cells. Of course, the naive B cells eventually will get trained to become plasma cells, and the naive T cells will eventually become trained to become CD8 positive T cells or CD4 positive T cells. So this is the normal hematopoiesis of the lymphoid half of this chart. Now let's go to the other side. Again, the hematopoietic stem cell has the ability to produce a myeloid stem cell, and the myeloid stem cell can develop into an erythroblast, which would then produce red blood cells, can develop into a myeloblast, which would then produce granulocytes, and the granulocytes are the neutrophils, basophils, and eosinophils. It can develop into a monoblast, which would eventually produce monocytes, or it can develop into a megakaryoblast, which would eventually produce megakaryocytes. Of course, we can draw a line here. This represents the myeloid half of the chart. So these are the myeloid cells, and these are the lymphoid cells. So this is normal hematopoiesis. Now, some of the problems that can occur with hematopoiesis is that we may get a circumstance in which we overproduce cells or underproduce cells or have a neoplastic proliferation of cells, and that's what really the remainder of this chapter is all about. Again, the cells mature as the hematopoietic stem cell begins to produce cells. The cells will eventually mature, and it's the mature cells that are released from the bone marrow into the blood. I think that's fairly obvious. The normal white blood cell count is about 5 to 10,000. If the white blood cell count is less than 5,000, we call that leukopenia. And if the white blood cell count is above 10,000, we call that leukocytosis. Now, what I'd like to establish here is that when a patient has a leukopenia, or when they have a leukocytosis, the leukopenia or leukocytosis is usually predominantly due to one cell type. For example, one possibility is something called neutropenia. Neutropenia refers to a low number of circulating neutrophils. And this is classically seen with drug toxicity. The example would be chemotherapy. A classic conventional chemotherapy prohibits the division of cells, and it will affect both cancer as well as the rapidly dividing cells in the human body. And the hematopoietic stem cell and the bone marrow's progenitor cells are obviously rapidly dividing. And so it's not uncommon for patients on chemotherapy to actually develop a neutropenia. One of the pharmacologic tie-ins here is that such a neutropenia would be treated with GM-CSF or GCSF. GM-CSF, granulocyte monocyte colony stimulating factor, and GCSF is granulocyte colony stimulating factor. Both of these can be used pharmacologically to boost granulocyte production in a patient, for example, that is undergoing chemotherapy. And examiners like you to know that both GM-CSF and GCSF can be used to boost the neutrophil count. Another mechanism by which neutropenia can develop is severe infection. When we think about infection, we think about a high neutrophil count. However, if the infection is very severe, it is possible for the neutrophil count to decrease, and that's because most of the neutrophils would be out of the blood and in the tissue. Another example of a low white count could be due to lymphopenia, and lymphopenia would be a low number of circulating lymphocytes. Classic causes include immunodeficiency. Let's take, for example, DiGeorge syndrome. In DiGeorge syndrome, remember that the patients have a failure to develop the third and fourth pharyngeal pouch, and because they fail to develop the third and fourth pharyngeal pouch, they fail to develop their thymus, and therefore the T cells don't develop properly. And so these patients can actually have a lymphopenia. Another example of a lymphopenia would be a high cortisol state. Cortisol or corticosteroids induce apoptosis in lymphocytes, and so that would also produce a lymphopenia. For example, if a patient had Cushing syndrome in which there was a high amount of cortisol floating around in the serum, that high amount of cortisol would induce apoptosis of the lymphocytes. Autoimmune destruction can also result in a lymphopenia. The classic example would be a patient with lupus. Recall that patients with lupus often produce antibodies against cells within the blood. They can produce antibodies against the red blood cells. They can produce antibodies against the white blood cells, and they can also produce antibodies against the platelets. And so lupus would be one example in which we might see a patient who has lymphopenia. And finally, whole body radiation can also result in lymphopenia. And it's important to note, and examiners like you to know, that the most sensitive cell in the human body to radiation are the lymphocytes. When they get hit with radiation, they die very quickly. If you suspect in a patient exposure to whole body radiation, you could look at the lymphocytes and see whether there is lymphopenia, because that would be the first cell or one of the earliest cells to actually be damaged by the radiation. It is also possible to have an increase in our white blood cell count, and one example by which our white blood cell count might increase is neutrophilic leukocytosis. In neutrophilic leukocytosis, there is a high number of circulating neutrophils. And this goes back to the central principle of inflammation, which is that there are two driving forces for acute inflammation. Number one, bacterial infection. When there is a bacterial infection, the neutrophil count goes up, and therefore we would have a neutrophilic leukocytosis. At the same time, tissue necrosis can also result in a neutrophilic leukocytosis. As you will recall, I mentioned in the inflammation lectures that the two driving forces for acute inflammation are bacterial infection and tissue necrosis. So these two circumstances will result in a neutrophilic leukocytosis. Now, what I'd like to also highlight is that in these two circumstances, the bone marrow will be pushed to release as many granulocytes and neutrophils as possible. And so one way by which the bone marrow will respond is by releasing cells that are slightly immature relative to the mature neutrophils. This is called a left shift, and one of the high-yield important points to recognize concerning a left shift is that when immature or precursor neutrophils are released into the blood, those cells are characterized by decreased FC receptors. And of course, FC receptors are important because they help the neutrophil to recognize immunoglobulin, which is going to act as an opsonin for phagocytosis. So there's going to be a decreased expression of FC receptors in immature neutrophils, and so they don't function quite as well as a mature neutrophil. Examiners also like you to know that CD16 is the marker for that decreased FC receptor. And so we could summarize it by saying that when patients have a left shift and immature neutrophils are released into the blood, those immature neutrophils are going to have decreased CD16, i.e. decreased FC receptor. And that is actually an important principle that shows up on examinations. Now, the third way by which we could develop a neutrophilic leukocytosis would be to have a high cortisol state. Now, remember from our discussions in inflammation that I mentioned that neutrophils exist in sort of two groups. One group that's floating around in the serum, and the other group that is called the marginated pool. And the marginated pool basically sits in the blood vessels, but is stuck to the endothelium, or the lining of the pulmonary vasculature, the vessels in the lung. So these neutrophils are sort of hanging out, almost like bats in a cave. When there is a high cortisol state, cortisol disrupts the ability for adhesion to occur, and when this disrupted adhesion occurs, this causes the adhesion to break and drops the neutrophils into the blood. And so patients who have a high cortisol state, they're actually going to get a high neutrophil count because the marginated pool is going to fall into the blood. And it's kind of interesting, if you give a patient steroids, the white blood cell count goes up. And again, that's because the steroids have disrupted the adhesion of the marginated pool, forcing the marginated pool of neutrophils to then fall into the blood, which would then increase the neutrophilic count, giving us a neutrophilic leukocytosis. Another possibility would be to get a monocytosis. That would increase the white count. Monocytosis, very straightforward. is seen in chronic inflammatory states and is also seen in malignancy. Eosinophilia can also increase the white blood cell count. This is an increased number of circulating eosinophils, classically seen in allergic reactions, classically seen in parasitic infection. One very high yield association for eosinophilia is Hodgkin's lymphoma. In a subset of patients with Hodgkin's lymphoma, there is an increased number of eosinophils both associated with the tumor and circulating around in the blood. And examiners like you to know that the mechanism by which this eosinophilia occurs is increased IL-5 production. So in the case of Hodgkin's lymphoma, the mechanism by which the eosinophilia occurs is increased IL-5 production. Basophilia refers to a high basophil count, and for all practical purposes, the one place that we're going to see this is CML. Again, basophilia classically associated with CML, relatively high yield principle. Lymphocytic leukocytosis would be a high white blood cell count due to lymphocytes, and it's classically going to be seen in viral infections. Recall that viral infections are going to be fought and handled by the CD8 positive T cells. And so the CD8 positive T cells are the ones that are going to be present within the blood as they head towards the viral infection or are activated by the fact that there is a viral infection. And that would result in a lymphocytic leukocytosis. One interesting organism that can cause a lymphocytic leukocytosis is Bordetella pertussis. Now obviously this is a bacteria, and bacteria generally don't cause lymphocytic leukocytosis. Instead, we'd expect to see neutrophils, but this is the one exception, and because it's an exception, it's relatively high yield for examinations. This bacteria actually produces a special factor called lymphocytosis promoting factor. The lymphocytosis promoting factor blocks lymphocytes from leaving the blood to enter the lymph node. Now recall that lymphocytes are produced in the bone marrow, and then they go into the blood, and eventually they need to go to the lymph node in order to learn how to develop antibodies or to get stimulated to be able to fight infection. And so if the lymphocytes are blocked from entering into the lymph node, they'll actually be stuck in the blood. Then if they're stuck in the blood, there'll be a lymphocytic leukocytosis. Here we get an opportunity, and I put it here because there really is no other place in the text to discuss it, but here we're going to take a little diversion, and we're going to discuss infectious mononucleosis. Infectious mononucleosis is an EBV infection, most commonly, that results in a lymphocytic leukocytosis because we're dealing with a virus, so the lymphocytic leukocytosis would be fighting the virus, and that lymphocytic leukocytosis is comprised of reactive CD8 positive T cells. That makes sense. Again, EBV is the more common cause, CMV is a less common cause. The virus is transmitted by saliva, and in fact this disease is also called kissing disease, and it classically affects teenagers. When an individual gets an EBV infection leading to infectious mononucleosis, there are three tissues that are going to be infected. The oropharynx will be infected, giving the patient a sore throat. The liver will be infected, giving the patient hepatitis, and EBV is an important cause of hepatitis. And the B cells will be infected. Now, in response to the infection, there will be a CD8 positive T cell response. Of course, if there's a virus, the virus will take over the genetic machinery of the cell. It will then express viral proteins on MHC class I, and the CD8 positive T cells will recognize that MHC class I. When there's a CD8 positive T cell response, that will result in a few things that will be apparent clinically. The patient will have generalized lymphadenopathy, i.e. the lymph nodes, multiple lymph nodes, will become enlarged. It's important to know for the purposes of examinations, and they like to ask, which area of the lymph node will be enlarged. That requires a little bit of background. Remember that in a lymph node, we have a cortex, then we have a paracortex, and then we have a medulla. And in the cortex is where the B cells live, and the paracortex is where the T cells live. And so when we have a EBV infection and infectious mononucleosis, there's going to be hyperplasia of the paracortex. So it's important to know that in the case of generalized lymphadenopathy, the problem is going to be, or the area of expansion is going to be the paracortex. Again, that's a nice way to test normal histology. Also present in these patients will be splenomegaly. Why would we see splenomegaly? Well, remind ourselves that the spleen is made up of red pulp and white pulp. The red pulp contains blood, and the white pulp contains lymphoid tissue. Now, within the white pulp, there will be B areas and T cell areas, and the T cell area will be expanded in this particular circumstance. Important to note from normal histology, and again makes for a high-yield examination question, exactly which area of the white pulp will be expanded, and that is the periarterial lymphatic sheath. Periarterial lymphatic sheath, also called the PALS. Recall from histology that if I draw you a picture of the spleen, there's red pulp and there's white pulp. And the red pulp looks red, and the white pulp looks blue. It has a bunch of blue lymphocytic-like cells, and that within the white pulp you see these arteries, and the arteries have very dense blue around them. This is a classic histology. And this is called the periarterial lymphatic sheath, or the PALS. And it so happens that it's this area here where the T cells are present. And so this area around the vessels will be expanded, causing the entire spleen to become bigger, giving the patient splenomegaly. The third consequence of having a CD8 positive T cell response is that the patient will develop a high white count with atypical lymphocytes. Those atypical lymphocytes are actually CD8 positive T cells. Here's the atypical lymphocyte, and a few reasons why it's atypical. Number one, look at the nucleus. The nucleus here is much bigger than the adjacent red blood cells. Now that's a little bit abnormal because normally the lymphocyte of the nucleus is about the size of the red blood cell. So the nucleus is too large. At the same time, it has this abundant blue cytoplasm, which a lymphocyte usually doesn't have so much cytoplasm. So these are some important atypical features. Now when you see this cell, it almost looks like a monocyte. And in fact, if you think of the name infectious mononucleosis, initially we thought that these were monocytes, and so we called the disease infectious mononucleosis. However, we later learned that these are actually reactive T cells. So again, important to note that these cells are CD8 positive T cells. When a patient is suspected to have infectious mononucleosis, we screen for the disease via the monospot test. The monospot test is interesting because the basis of this test is that it detects IgM heterophile antibodies. What are heterophile antibodies? Hetero means other and phile means loving. And see, these are antibodies that have an affinity to bind red blood cells from another animal. And so, for example, patients who have mono will develop IgM against sheep red blood cells or horse red blood cells. And it's these antibodies that can be detected using the monospot test. The monospot test usually turns positive within 1 week after infection. If it's negative, it could be that we tested too early, or it could be that the disease is actually due to CMV. So when the disease is due to CMV, then the monospot test is usually negative. And again, CMV is also an important cause of infectious mononucleosis, and examiners like to go after that. So patient who's got the classic signs and symptoms of infectious mononucleosis but doesn't have EBV, think about CMV. We should also remember that the monospot test is merely a screening test, and a general principle in medicine is that every screening test must be followed by a confirmatory test. The confirmatory test for mononucleosis would be to prove that the patient has EBV, viral capsid antigen. Complications of infectious mononucleosis include an increased risk for splenic rupture. This is very high yield. Patients who get infectious mononucleosis get splenomegaly, and because there is splenomegaly, the capsule of the spleen can easily rupture. Generally speaking, or classically speaking, we would advise patients who have infectious mononucleosis to avoid all contact sports for the next year. And of course, examiners like to go after that principle. Additionally, if patients are exposed to penicillin who have infectious mononucleosis, they can develop a rash. And finally, the virus infects B cells, and it can remain dormant within B cells. And the complication of this dormancy is actually twofold. First, it increases the risk for recurrence of infectious mononucleosis, and second, there is a risk in the future of development of lymphoma, especially if an immunodeficiency develops. Recall from our discussions in neoplasia that EBV is associated with an increased risk of lymphoma, and particularly in patients that are immunodeficient, for example, AIDS patients. Here's a picture of splenic rupture, and again, just to remind you, in patients with infectious mononucleosis, the spleen enlarges, and when the spleen enlarges, there's a risk of rupture. All patients with infectious mononucleosis are classically told to avoid contact sports for up to 1 year after resolution of the disease. And this closes off our discussion of leukocytosis and leukopenia, and we'll move on next to acute leukemia.